CHF develops from left-sided heart failure. Left-sided heart failure often develops from either MI or non-controlled hypertension, increased systemic vascular resistance. One of the things that you do see with left-sided heart failure is that the right side continues to pump normally. So what this eventually does is overloads the left side, and so then you have, through the process passing through the alveolar capillary membranes and all that, you have the fluid through hydrostatic pressure being pushed against the walls and then through into the lungs. This is where you get your pulmonary edema. So you do have cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema is a type of pulmonary edema you would see with acute respiratory distress syndrome. I'm sure they're probably seeing a lot of non-cardiogenic pulmonary edema with these severe patients with this COVID-19 that's going on right now. Also toxin-induced, and we'll talk more about that type of pulmonary edema next semester. Your cardiogenic pulmonary edema, that's going to be your pink frothy sputum. It's going to be blood that's being pushed back up. May also see Cheyne-Stokes respirations, which is increasing rate and depth of respirations followed by a gradual decrease in respirations, and this is going to be to compensate as that fluid is building in the lungs and the oxygen exchange is becoming impaired. With our left-sided heart failure, we're losing forward movement, so we're losing cardiac output, but we're gaining fluid in the lungs, in the alveolar space, in the capillary space, and in the interstitial space. If you see here, this is an image of a alveoli that should be full of air, but instead it's full of fluid. So when the air comes down, it mixes with that fluid, causing that frothy appearance, and it's blood. This is where you're going to hear wheezing, possibly, crackles. Our best treatment for this is going to be to put them on CPAP. Foamy blood-tinged sputum, work of breathing increases, dyspnea and hypoxemia. Also release of epinephrine, your catecholamine release, to help compensate, which in turn is going to cause an increased oxygen demand. With this, when you have that sympathetic response, that epinephrine release, what's going to happen? I just mentioned it, the oxygen demand is going to increase because of peripheral resistance, or your afterload increases, which means your cardiac output has been decreased, which means that the fluid is going to back up into your lungs, and it just makes everything much, much harder. So when they're having a exacerbation of heart failure here, extreme restlessness, agitation, dyspnea, tachypnea, tachycardia, crackles, wheezes, it's going to be an emergency situation for you guys, an exacerbation left-sided heart failure. Another interesting thing that you may see is what's called a Cannon atrial wave. This is pulsations that you may see within the jugular veins. You may see some changes with the P waves on the ECG. It's really neat. I'm going to show this little video right here. You don't have to have sound if you'll just look at the jugular vein right here. If you notice right there, it won't let me go over it. Well, there it is. If you notice that he had those pulsations in his jugular vein there. Let me play it again, if it will. Right there. So that's pretty weird. So your management for left-sided heart failure is going to be improving oxygenation, decreased workload of the heart, trying to move some of that fluid out of the space where air should be. So CPAP is certainly going to be one of the things that you need. It says administer 100% oxygen by demand valve or bag mask device, but if you're only trying to supplement oxygen and you're not trying to help ventilation, then you're not going to have anything good happen for that patient. Other things, pharmacological therapy, nitroglycerin, that's going to be a big one. That's going to be important there. That's going to help open up that vascular space and help with allowing that blood to kind of stay more in the container than actually being pushed out. Your furosemide or any type of diuretic that may be prescribed per the doctor, I would not depend on a diuretic to help emergently, though. They do work pretty quick, but your best bet is going to be CPAP, because with your diuretics, you can't really control electrolytes. You don't really know what's happening with the electrolytes, and also you've got to have a place for them to urinate too. They're going to pee all over themselves. Morphine. Morphine really has been shown that it really doesn't have that great of vasodilatory effects when used to. Morphine was common treatment in left-sided heart failure, pulmonary edema, because they said, it's a potent vasodilator and it'll work like nitro, but it really doesn't. If you're giving morphine in this situation, you're really giving it more for the analgesia and the feel-good effects. Your bronchodilators, if they're wheezing, but remember, if the wheezing is not caused by bronchoconstriction, but because of edema or pulmonary edema, it's not really going to do a lot in this case as far as fixing wheezing and things like that. Now, they may also require a vasopressor, such as dopamine, if their heart just becomes so overloaded and you lose that cardiac output, they become hypotensive and things like that. All right. Mentions transport the patient with legs dangling. That is to help with the fluid and gravity pulling it down. It can support the body while, then the other thing is if they're in heart failure, there's no reversing it, so they may have to get what's called an LVAD. An LVAD, essentially, there's two reasons why somebody might be prescribed an LVAD. Either they are on the transplant list and they are waiting for a heart, or they're not eligible for a transplant and they are given this to extend the quality of their life for a little longer. It is a battery operated pump. It's sometimes implanted during heart surgery for people who are waiting for a heart transplant. It actually would be implanted where it takes it essentially just takes the place of the left ventricle. All right, so goes through and then it gets to your left atria, and then it actually pumps through into the aorta. So it actually essentially takes place of all of the big things that would be necessary for your heart to continue getting blood to the body. Because LVAD assumes pumping function of the left ventricle, the patient may have no palpable pulse or measurable blood pressure. So you're going to have to, it'll be obvious that they have this. Don't assume that you're the expert on the LVAD. You should, if there's an LVAD in the area where you're working in your service area, typically the vendor of that particular LVAD will come to the area first responding agencies and the ERs and stuff and do training on them. Many the patients with LVADs advise emergency services agencies so that the personnel can be made aware of their special equipment needs. Just like I said, it is important to be, to understand that. Now, I need to take this out right here, so don't pay attention to this slide here. I keep saying I'm going to, and I haven't yet, but I will take it out. You can, and it is recommended that you do CPR for a patient with an LVAD. Used to, they said don't do CPR for the LVAD. Now you do CPR for the LVAD. If if you, it does say here, procedure for defibrillation and cardioversion will be specific to LVAD and manufacturer's recommendations. American Heart Association just says, you know, treat it as you would a normal cardiac arrest. Okay. Right-sided heart failure. So the difference here is where the blood's going. The blood's actually going into the periphery instead of into the lungs. Right-sided heart failure is usually caused from left-sided heart failure. So think about this for just a minute. If you have a patient that has left-sided heart failure, and then they develop right-sided heart failure, it actually may improve. Dom said he lost power. Jeez. Okay. It may actually improve your left-sided heart failure. Why? Because now the decrease in output is decrease in preload. You've got a decrease in output from your right ventricle, so that's going to help with what's going into the left side, which in turn will lessen pulmonary congestion. Typically, you don't have acute exacerbations of right heart failure. You typically aren't treating a lot of patients that have right-sided heart failure as their main issue. Another thing that you might see with somebody with right-sided heart failure is going to be the extended neck veins. You may also see edema in the lower body. Also, an engorged liver or spleen. They may also have what's called the hepatojugular reflex, where especially in somebody that's real thin, you can feel their liver and you can palpate it, and it actually might push blood back into the jugular vein when you palpate it. So, any questions there? All right, just checking in with everybody. Y'all still good? Y'all still hanging with me? Okay. All right, cool. All right. Hey, Jabbar. I've never seen it. I've never. It's just the reflexes mentioned in your book. That there's other things, you know, that would be able to tell you, and that there's really not any reason. Your book does mention it, but that's just, you know, just like saying the JVD is part of it and all that. This is something you may see. Honestly, there's no reason to press on the liver if you can see everything else. So. Okay. All right. All right, cardiac tamponade. Cardiac tamponade. Somebody have a question? Y'all good? Cardiac tamponade. The big issue here is that you got the fluid. Oh, forgot I had these headphones on. You got the buildup of fluid. It's going to affect your contractility. Old Frank Starlin's law is going to be affected here. And really, the main treatment for cardiac tamponade is going to be a pericardial centesis, which we will not perform in the field. But do know that you've got Beck's triad for cardiac tamponade. That's a test question favorite, Beck's triad. Muffled heart tones, hypotension, and JVD. All right, that's your Beck's triad: muffled heart tones, hypotension, and JVD. Okay. You also may see what's called a pulsus alternans and electrical alternans. Your electrical alternans right here is where you've actually got varying axi. I guess that's it. The axis is different with each beat, if you notice that. Pulsus alternans is characterized by alternating strong and weak pulse pressures during a sinus rhythm, and then pulsus paradoxus is defined as a fall of systolic blood pressure of greater than 10 millimeters of mercury during the inspiratory phase. Often difficult to distinguish between cardiac tamponade and tension pneumothorax other than one particular thing, and that's going to be what? Yeah. With tension pneumothorax, you're going to have unequal breath sounds. $1 says I'll see that on a strip within the week. For a minute there, Dom, I thought it said $1 and I'll strip within a week. I was like, oh, you can log off. It'd be like that. All right. So yeah, your treatment is going to be a pericardiocentesis. Nothing really we're going to do in the field other than just be supportive of them there. All right. One of the important things, cardiogenic shock. Cardiogenic shock is going to be seen in your ROSC. It could be seen in hypovolemia. It could be seen in heart failure. But cardiogenic shock is pump failure. So we know that the definition of shock across the board is inadequate cellular perfusion. No matter what way we get there, it's inadequate cellular perfusion. In this case, it's because we have an output problem. The heart cannot pump. It's a supply and demand. The heart cannot supply what the body demands. Why is that? Because there is a issue with the pump. The pump is broken. So you can have a pump that's pumping water, and on one side you can add all the water you want to, but if the pump doesn't actually create the suction and then actually force the pump out the other side, all you're going to do is continue to add fluid to one side of the pump. And that's typically what's happening here. This is one of the big reasons why you need to continue CPR for 2 minutes, even after you receive ROSC, because they're going to be in cardiogenic shock. They're going to, their heart has not been pumping well, and you can't just expect it to suddenly just take over again. So that's why you do want to do 2 minutes of continued compressions afterwards. Also, you're going to see the other signs that are similar to other signs of shock. And it all boils down to the body's trying to compensate. It certainly is not going to compensate very well in this situation. You're going to see a release of catecholamines that hopefully will improve the heart rate a little bit, may cause vascular constriction. But again, with shock, you've got several different modalities. With cardiogenic shock, it's not a fluid problem and it's not a distributive problem. It is a pump problem. You've got enough fluid. Your vessels would work fine with a constriction to provide the pressure and all that. The fact is that there's just nothing you can do with the fluid because the pump is not working. So what would be your goal? And somebody can pipe in here. I'll just to hear from you guys. What would be your goal in cardiogenic shock treatment? What would be your goal in cardiogenic shock treatment? Okay, all right. We don't want to lower blood pressure because your treatment is going to be focused primarily on your heart. What are you going to want to do in particular to the heart? There's one thing really important. All right, you want to get it pumping. It probably is pretty excited. If you were to look at the electrical conduction, it's probably pretty excited. but you want to get it pumping, and what, there's another property there. Not, there it is. There it is. So yeah, Andrew just he just said increase stroke volume. So yeah, that's exactly what you want to do. You want to increase contractility to increase stroke volume to increase cardiac output. So what drug are you going to possibly use a cardiogenic shot that you've got readily available? Dopamine. So this is where you would do a dopamine drip. Now, remember, in this case, though, this is different than if you were giving it for sinus bradycardia, because if you were giving it for sinus bradycardia, your main focus is to get that heart rate up. So you can give higher dosages where it starts affecting the alpha adrenergic receptors as well. In this case, though, we don't want to tax the heart any more than what we have to. So this is going to be the case where our dosage is 5 to 10 mics per kg per minute. Does that make sense? We're really just trying to get the inotropic properties of dopamine here. So yeah, that would be one of your big treatments there. The physician may order a trial of fluids. Now, one of the things that's always kind of got me is that American Heart Association recommends in the return to spontaneous circulation 1 to 2 liters of fluid, and I still just struggle with loading somebody with fluid because of the fact that the heart just can't pump. So they may recommend a trial of 100 to 200 milliliters of saline to maybe help kind of get the prime going again, get things pumping again. But in true tried and true cardiogenic shot, they're going to need some kind of inotrope. Okay. May also consider a levofed drip or a epi drip as well. The problem with all of these, though, even across the board now, it does have on this is, I don't agree with this right here, 2 to 20 mics per kg per minute. But the problem with all three of these drugs is what? What type of drug are these? Don't be afraid. Somebody. Yeah, they're sympathomimetics or sympathetic drugs. So it's going to increase the workload on the heart no matter what you give with these drugs. There's really not anything else there. So if you are going to give a perfect drug, what you would want to do is increase the contractility without increasing the excitability, but that's not really going to happen here. Okay? Questions? Nope. Cool. Aortic aneurysm. You've got aortic in the thoracic wall, and you've got AAA. Do know that if somebody's experiencing an aortic aneurysm, there is a difference in them experiencing signs and symptoms from a from it starting to dissect versus a absolute rupture. If somebody ruptures an aorta, then unless they're laying on a surgical table with their chest open, there's really not a lot to do in that case that's going to prevent them from essentially bleeding out. Essentially, you start getting the weakening of the vessel walls. You've got your 3 layers of your vessels. You've got your tunica intima, your tuna media, and your outside tunica as well. Forgot the name of it just right off the top of my head. But essentially, you've got the layers that are glued together, and as the pressure pushes against them, it just essentially separates. So you may actually have inner wall tearing of the vessel, but then your outer wall is still there. So this is what causes the ballooning out. Dissection begins after the intima, or the inside, is torn. The coronary blood flow will be affected. The takeoff point of the left common carotid or left subclavian artery is where the arterial blood flow will be affected. All right. If you start having an acute situation where they're dissecting, they may have sudden chest pain. You may see unequal blood pressures on the left and right side, especially if it's lower. If they've got a history of Marfan syndrome, which is an inherited disease that affects the body's connective tissue, one of the biggest threats of Marfan syndrome is damage to the aorta. Several famous people have Marfan syndrome. Michael Phelps actually has Marfan syndrome, which makes him so good at swimming. If you look it up, a lot of his features makes him very good at swimming. But Marfan syndrome is one of the risk factors for a dissection of the aorta. If you suspect aortic dissection, you certainly need to be very, very careful with them. Transport them very calmly, and you don't want to do any sudden jerking or any sudden movements or anything like that, because you don't want that aorta to actually rupture itself. So it says IV line and give crystalloid solution, but you don't want to have a fluid bolus running. Okay. If someone has an aneurysm that gets larger and larger and larger, rupture is going to be imminent with that. A AAA, this is when you learn in basic, if you are doing an abdominal assessment and you feel a pulsating mass, then, this is where you would see that. As it expands, the symptoms the symptoms begin with a sudden onset of abdominal or back pain. This is going to be in your AAA here. They also may have a fullness feeling, an urge to defecate. You may see this pulsatile mass. They may be normotensive at first, but then you start seeing decreases in blood pressure and all that. This is where you do want to transport without delay. You may see unequal blood pressures on the left and right side, things like that. All right. Last few things here, hypertensive emergencies. So there are drugs in your toolbox to handle hypertensive emergencies. Typically, blood pressure at rest is greater than 140/90, but you've got to have more than just one reading for somebody to actually be hypertensive. So the big thing that where folks start becoming diagnosed for hypertensive syndrome is after their diastolic pressure stays very high and continues to stay high. The thing about hypertensive disease, uncontrolled especially, if it stays high, I've talked about the triad before, hypertension, diabetes, and renal failure, because it affects the blood flow to all of the important organs, your kidneys, your pancreas, all of that. Some of the things that you really got to be concerned about in the acute setting with hypertensive emergencies is going to be stroke. They start having severe headache, dizziness, weakness, epistaxis, tinnitus, blurred vision, acute elevation of blood pressure with evidence of end organ damage. Now, there's also... All right, hold on. So I just heard somebody. Did somebody just type something? Oh. Did somebody just try to ask a question or something? I heard a sound. I don't know. Okay. Hypertensive encephalopathy. This is going to be affecting the brain. Hypertensive encephalopathy. I was trying to find it. Also known as acute hypertensive crisis, may complicate any form of hypertension. Hypertensive crisis is usually signaled by a sudden escalation of blood pressure of levels exceeding 200/130 millimeters of mercury. I mean, this is not compatible with life for very long. And so there's going to be a lot of things that go into this. This is a dire emergency for these patients, and we need to make sure that they get what they need. Now, you may be ordered to administer like a beta blocker or something like that. Their blood pressure needs to be controlled, though. It needs to be lowered in a controlled manner. We don't need to bring it down from 200 and something down to 120 just very quickly, but we do need to try to manage it. You may also you may be asked to give a dose of nitro. They most likely will be on a nitro drip in the hospital to slowly bring it down, or they may be on a beta blocker drip or something like that. The big thing here, though, like I said, is that you're very concerned about changes neurologically, because you could have vessel rupture, which uncontrolled hypertension is one of the risk factors for stroke. There's a couple of infectious diseases of the heart, endocarditis, pericarditis. I'm going to let you guys go back and read over those. Treatment for all of these are going to be antibiotics. But there are some unique things that may go along with them as well. We're not going to really do a lot of treatment in there. Rheumatic fever and scarlet fever, these both can cause mitral valve issues. Scarlet fever also has what's called the strawberry tongue. So I would recommend going over those and just reading those for testing purposes for sure. Mine's just making sure that pretty much covered that stuff there. So I've got a little case study. I would really appreciate it if somebody would answer here if you can. You and your partner are called to the scene of a rural residence where you find a 57-year-old male who is complaining of chest pain. The patient reports a history of recent surgery that was performed to repair a fractured pelvis. Approximately 2 hours ago, he began to experience tightening in his chest discomfort, and shortness of breath. He now reports that he is nauseated. So with this patient, what are your initial considerations? Okay. Yeah, definitely. What would you ask him as far as, like, since he's had the surgery? What would you ask him what he's been? Okay. All right. Shortness of breath. Has he ever felt something like this before? Did they give any medications for any anticoagulants? There's no blood thinning medications, but anticoagulants. Okay, yep. His history. Andrew, I got you. Your cardiac history. Does he have any other heart conditions? Yep. We need to get a 12 lead. Fever? Yep, definitely. Another thing that you want to ask, all of those are excellent questions that we are going to ask. Another thing you want to ask is what was his mobility? How much has he been moving around since that surgery? Has he just been laying around? Because one of the things that's very, very important is after surgery for you to move around. It helps bust up, or it helps keep from getting any of those clots. Yep, here you go. Has he been active or bedbound? There it is. So yeah, you want to get all of that information there. Definitely some good answers there. Patient's level of consciousness, airway, breathing, and circulatory status as well. So your partner records the patient's vital signs as follows: 180 over 120. His pulse is 140. Respiratory rate is 32. And on the monitor, boom, bam. What would y'all call that? Yeah. Yeah, that's what it looks like to me. So before initiating drug therapy, what questions would you ask the patient? And we've already talked about that. Allergies, have you experienced this type of pain? Yep. What medications are you currently taking? So 5 minutes into your management of this patient, his blood pressure drops to 130/74, and he exhibits a decreased level of consciousness. Yep. Um, yeah, he's just taking a nap. So in this case, his blood pressure is still good. So I didn't mean to have this up here, right here, but you would consider amiodarone in this case. It's, you could try maybe adenosine, but amiodarone 150/10 minutes is going to be your best bet. And then if his blood pressure continues to drop, or if he starts to become unresponsive, well, he does exhibit a decreased level of responsiveness, and you probably want to consider cardioversion as well. All right, that was very anticlimactic right there, so sorry about that. So in summary of all of what we've just talked about, most cardiac arrest victims have atherosclerosis or other underlying cardiac disease. CAD is a leading cause of death of adults in the United States. In cardiac tamponade, excessive fluid accumulates within the pericardium, limiting the heart's ability to expand fully. Cardiogenic shock has a high mortality rate. Aortic aneurysms are a great concern, with the most common complaint of sudden, severe ripping or tearing pain in the chest or abdomen. Hypertensive emergency treatment includes slow, controlled lowering of blood pressure, with management of elevated blood pressure reserved for ED physicians, because remember, we don't want to just drop it really, really quickly. And then in cardiac tamponade, excessive fluid accumulates within the pericardium, limiting the heart's ability to expand fully. Are there any questions on what we just quickly went through right there?